Thank you, Anna. That was fantastic, if at times really salutary. And I think one of the challenges we face as adult social care is up and down the country, there will be some fantastic examples of really good practice and where local authorities have done the least amount they need to do to help people be as independent as possible without interfering and becoming overbearing. But equally so, there are some places that need to step up their game. So thank you for bringing it really, really alive. Before I introduce our next speaker, can I just remind people of Slido? So download the app. We're going to use that for question and answers at the end of the session. So moving on to our second speaker, I'm really pleased, genuinely really pleased to introduce Matthew Winn, Director of Community Health and the SRO for the implementation of the Aging Well programme, and has been leading the work to around hospital discharge. Anna mentioned the interface between health and social care, as did I. It would be really great to hear your thoughts, Matthew, about that and how that can contribute to personalised health and social care. So without further ado, over to you, Matthew.
Thank you, and it's a delight to be with colleagues from ADASS across the country, and thank you for that warm introduction. It's always been nice to be encouraged to come rather than just come. I think what I wanted to do, colleagues, is just put both a national and a local approach to how we have done our health and care interface during the COVID period, and then the impact on our local communities and the impact on personalised care. I have two jobs in my life. I am a job in chief exec in an NHS organisation across the east of England, providing community health services, and as we said on the slide, National Director of Community Health Services. And that has monopolised a lot of my time during COVID, as I had responsibility in the COVID period for NHS England on community health, hospital discharge, and the healthcare support for social care. Three just themes for me before I just talk to some content on the slide. One, we obviously did things in a hurry at the beginning of the COVID crisis. I have to say I've never worked so many hours to try and align things at the beginning of March and to allow and give permission to systems to do something different. So the major one I was involved with was obviously the implementation en masse across England of the hospital discharge to assess process, and the prioritisation of what community health services would or wouldn't do during the COVID period. And so I know people have used that as a framework to therefore change what they are doing, and really have used it as a permission to say we won't do things as they may have always been done because we have patterns of behaviour and culture and bureaucracy in our local area. We will look to change them. I think the other thing second area I would just focus on, and I couldn't at all kind of amplify any further than Anna did on the impact of the support for people who were shielded. But what I would say, and I see this in some of the local areas that my trust works, it has turned into a really impressive opportunity for people across health and care and our community sector and our local communities to actually understand how they can provide much more personalised approach. And I think from a registered clinician perspective, probably challenge them very much to stop being so paternalistic in that the state has to do everything. And in that respect, I think has been quite liberating. And I think the third area I would just focus on is that actually going back to that word permission, I have been challenged and continue to get challenged by health and care professionals and leaders to say, how do we bottle the approach of that liberation that happened at the beginning of COVID and allow that to continue and almost declutter what we do. And I will talk about that in a second. So if I just move to my first slide, One thing that happened early on in the COVID area crisis is that, as I said, we started the discharge to assess process. If we could move the slide on, colleagues. That had an immediate impact on quite a few things, but one of which was the impact of how people used hospitals. Obviously, overall across the country, people generally use hospitals about 40% less than they did previously. But in the health and social care interface world, that I think was most starkly seen by those that were in hospital for over 21 days, which massively reduced. I can't see my next slide. I don't know if colleagues online can. So there we are. Thank you. Looking at this slide, what this says, and these are scatter graphs below at the bottom, in the Midlands and East of England, we've highlighted, actually, these are acute hospitals. The bottom line is the impact on those with 21-day stays. And the top vertical axis is the impact on the occupancy levels of hospital. So what we did see was a 50 to 60% reduction across the country in people staying less long in hospital for those that have been in for over 21 days. And the reason I say that is not because this is about data and it is not about hospital utilization. Being in hospital for a long time is bad for people. It inherently means that they are less able to recover. They lose the ability to they lose the ability to retain the independence that they had previously. And we all know on this conference that lots of that has to do with how health and social care organisations work together to support people with quite complex needs to be discharged. So I think that's a really impressive different way of approaching that we can see that has happened. And there has been some massive changes in how people are used and stay in hospital. Next slide. I think what's also been interesting, and this is using the live data that hospitals now do start introducing, and some of this improvement goes down to data validity issues. So don't you view this as a trend at the moment, but the top box is the numbers of people being discharged home. And then the other box, the other lines are those that actually go into, according to the key, rehab beds or hospices or care homes. There are increasing numbers of people going home. The variance is, of course, weekends, where we have the downward spike happening. But actually, one area I will just alight on at the end is about how we can work together across health and care to give personalised approaches that actually that forces us to make sure that people are in their own homes to make big decisions about their future, rather than hospitals discharging people into places where they may not have wanted to go particularly. Next slide. What was interesting in things that were published during the COVID crisis, and I've just summarised things that I know you will have read in this audience from the Public Health England report about BAME groups. I want to just focus on the last one. One thing they recommend, which we need to absolutely take heart across health and social care world, is that actually there are recovery strategies actively to reduce inequalities caused by the wider determinants of health to create a longer term sustainable change. That's a mouthful, but actually we do need to make sure that in the planning that we do together, both nationally and at a local level, we are not perpetuating or making inequalities worse, that actually people have the abilities to access care at the right time, as Anna described, in a very personalised way, and actually use some of the impetus we have found during the COVID approach and crisis to actually ensure that happens. Next slide. So how will I do that as a national leader working and supporting you in local areas? I think just 3 areas that I would say, and I will one of them is ensuring, and this audience knows this as much as I do, that the home first mentality for that discharge world, and I'm sorry this is more focused on discharge, but it's something that actually is really important, that we get people home first, not go into care homes prematurely. All the work that both ADASS have done, Newton Europe, John Bolton, I could rain lists off, talk about that actually up to 40% of people being discharged from a hospital into a standard care home potentially go there prematurely. And therefore, we can do something about that, because that's about culture, it's about behaviour, and it's about our policy. So on Tuesday next week, you can expect that the NHS will, Simon Stevens and Amanda Pritchard will write out to the NHS talking about what our plans need to be for the rest of the financial year. In there will be about us maintaining and embedding the discharge to assess process in our local communities, a new pot of money that will take over from the COVID pot that we have all been using. And as it said in the second bullet area, that we will look to support people for a 6-week period paid for to allow them to recover and rehabilitate. My ambition with you all is that actually we get to the point where there are no discharges from hospital to a standard care home for a permanent placement direct, that actually we get to a position across the country where everybody gets the chance to go home, re-able, recover, and then the decisions about their ongoing care are made in their home environment. Now, I may be utopian and trying to achieve the world in that phraseology, but there are some systems in our country that are already doing that. And therefore, we all need to learn and think about the ambition that we put in about ensuring that we are given that personalised care and work across the health and social care divide and with our acute units to make sure that can become a reality. Next slide. Because this is what we are trying to achieve. In that policy area, we are trying to maximise the number of people that go home without any health and social care support. We are trying to then maximise that 45% of people that go through a reablement intermediate care world. We're trying to get to a point where the good evidence from John Bolton and others would say that only 4% of people go into a interim bed, a short-term bed, or a community rehabilitation area, and a very tiny proportion, maximum 1%, go directly into a care home, and that would be those with higher complexity about nursing. If we are able to move together in this approach, we will be able to get to better outcomes. And so I hope that the documents that will be published on Tuesday will give you, in your local areas, working with your health and care and voluntary groups, the ability to really be ambitious for our local residents to ensure that they get the right personalised care support. That does mean better support at home. The money the government has made available is non-recurrent to the end of this financial year. So my final word would be the challenge to us as leaders of our local systems is to absolutely prove and show the effectiveness of providing integrated care and supporting people with their independence in their own homes. Because I think if we can get our data, our outcomes, and our policy right, there is an absolute compelling case that that should be funded recurrently into the future and really be a good underpinning foundation for the integrated care that happens in local areas. Without your support on both implementing that policy, but also getting our data right to prove the effectiveness of what our wonderful staff do with local residents, we will not be able to argue that case articulately. And I would like your involvement through ADASS and wider council colleagues to make sure that we can do that and speak with one voice when it comes to arguing for better resourcing of these services in the autumn and into winter for next year. So that's all I wanted to say in terms of my introduction. I'm sure we can pick up further questions as we go through the session.
repeated following Anna's. So one of the key messages was we made real progress when we stopped asking for permission and realized that actually we could just get on and make a difference. Really important message around home first, helping people leave hospital, getting back to their own home, regaining and recovering their lives as much as is possible, and avoiding absolutely necessary, the need for long-term care and support. So I'm sure colleagues will have lots of questions for you, not just around the future of the hospital discharge service, but about how we can together ensure more people live really good lives at home.